Nagri Nangi, everyone. Nanawamichi Paul Worley, Napi Puteri Maudi, Pomerakunk, Natajeri Rui. G'day, my name is Paul Worley. I'm the Executive Director of Clinical Innovation here at Riverland Mallee-Coorong Local Health Network. I work at Murray Bridge, which is Natajeri country. And today we again can get together to be stimulated to think more broadly than the patient just in front of us, to think about what developments are happening around the world, to learn from them, and to look at how we might be able to partner more effectively with the advances in care that are occurring on behalf of our patients. One of the areas that South Australia is actually internationally known for is its work in the leukemias and the genomic specific treatments of leukemias. And people are recognising all around the world that increasingly treatment is becoming very individualised. The word that's often used for that is precision medicine or personalised medicine. Today, I have the pleasure of introducing and inviting to speak Professor Deb White, who is the theme leader for precision cancer medicine at the SAHMRI Institute in Adelaide. And it's fantastic, Deb, to be able to hear from you about your experience and perspectives on acute lymphoblastic leukemia and the implications that advanced genomics has now for treatment of people in our country and beyond. Deb, over to you.
Thanks, Paul, and thanks for the invitation to talk, and great to have met some of you at SAHMRI a little while ago. As Paul said, we do a lot of work in leukemia here. It's really one of the big areas of our precision cancer medicine theme. And that really, to be honest, stems from chronic myeloid leukemia many, many years ago. Chronic myeloid leukemia being a disease of chromosomal translocation between chromosome 9 and 22, giving rise to a Philadelphia chromosome, and it then giving rise to a tyrosine kinase, which in fact probably heralded the first precision cancer medicine treatment, which was imatinib, and its sisters that have gone from beyond that. So that was way back in the days of my PhD, actually. So I guess we've built in Adelaide on the strength of that, and now looking much more into other areas of different leukemias to understand how we can use precision medicine, as Paul mentioned. I've taken the liberty of saying acute lymphoblastic leukemia genomics 1, because this is really a very broad brush sort of talk. It doesn't dive too much into the weeds with respect to ALL. And I think it's probably the forerunner for something that we might talk about at a later stage, which is looking systemically, and kind of a new area for leukemia research, really, looking more systemically at the disease. But, you know, over the last decade, I think we have started to, globally at least, come into a stage where genomics is hit prime time. So it's no longer a black box, although parts of it still are, but indeed we can generate a lot of data. And actually it's quite scary. Hopefully it's not all scary, but it's actually taken us quite a while within the field, and this is a global experience to actually get this to the stage where we can use it in a way that may influence patients' outcomes. So we have the blueprint, if you like, and we're starting to put it together. We know that we're going to generate a huge amount of data, and we do, but we really need to then know how to use this so that we can influence patient outcomes. And the focus of our work in this area is in acute lymphoblastic leukemia. So a quick one slide, what is ALL? And I apologize to people who know very well what ALL is, but it is obviously a disease of the bone marrow and blood. The majority of these cases are B cell in origin, about 20 to 25% will see as T cell in origin. It's interestingly increasing, and I'm not sure we know why, and that maybe just more related to increasing diagnoses, but I'm not sure. The highest prevalence, regardless, remains in children. So it's the most common childhood malignancy. But it is a disease and actually a rare cancer that we see from neonatal stage right through until very old age. Relapsed ALL, we've seen great advances in the treatment of ALL, but relapsed ALL is really remaining a significant cause of non-traumatic death of children in the Western world. So even today, 10 to 15% of our children with ALL will die, and they'll primarily die of relapse disease. So it's a very slippery slope once you get into a relapse situation. So a lot of our focus, of course, is trying to understand the disease so that we can prevent that. The survival of neonates is poor, very poor, around 40%, maybe up to 50%, depending on the study. And adults and adolescent young adults. So adolescent young adults in ALL, just to set the scene here, are patients and aged between 15 and 39. So it's always nice for 35-year-olds to think of themselves as young adults if they have ALL. It's probably a disadvantage in that and having ALL, of course. So and we see really quite poor outcomes. So 40 to 50% overall survival, and the primary time of death in that disease, of course, occurs in the first couple of years. We also know that, with treating patients, the survivorship issues become real. And with the sort of therapies that we use in acute lymphoblastic leukemia, the chances of secondary cancers and significant comorbidities are very real. So why do we do genomics? Well, to some extent because we can, but that's not the only reason. It gives us a greater understanding of the pathways that drive the disease. It allows us to subclassify and assign a risk to patients' disease so that we know what approach to take with therapy. As Paul mentioned, precision medicine and the approach to therapy has come into this, but not hit as prime time yet. It's slow to actually come into the clinic, and there are good reasons for that. Our approaches, or the approach that I've taken in this disease when I set up the group, was to focus on clinically relevant expressed genes and gene fusions, and we see a lot of gene fusions in ALL. That's because we wanted to keep this translational and translationally focused. That's not to say that we don't do discovery research as well, but really this is, and you'll see on in a couple of slides, it's really patient-driven data coming back to the patient, but also discovery. We don't do much panel testing. It kind of went through a fad a few years ago, but in fact, in ALL, it being such a complex disease, designing panels is expensive, and the rate of sequencing is coming down. We do use MLPA for looking for focal gene deletions, and I'll show you a little bit of that in a minute. Minimal residual disease, of course, is now moving into the genomic space, but it's complex. And in fact, we're part of an Australia-wide collaboration. I don't do MRD analysis. There are other groups that do. So what do we know? So back in 2000, so the turn of the century, this is what ALL looked like. Still looks pretty complex, really, for a single blood disease, but we thought then there were 8 or 9 different subtypes of B-ALL and about 7 or 8 of T. Interestingly, if we look at the cytogenetic classification of ALL even now, it wouldn't change much because we've really hit the level of detection using techniques such as cytogenetics. We knew from this work that there were good subgroups like ETV6 RUNX1 and hyperdiploid ALL, where patients did really quite well, and ETV6 RUNX1, we see long-term survivors, as we do with hyperdiploid. But if we look at patients who had MLL rearrangements or KMT2A, BCR-ABL, of course, we know is a high-risk disease in the ALL setting, or hyperdiploid, we knew they did badly. So we had some subclassification, but we also knew that there was this group of patients that we knew nothing about. Basically, very little. They appeared to have normal karyotype, but we also knew that they were the bad players. So there was a really quite large subgroup of these patients who did very poorly. And this has been a global effort to understand that group of patients that we knew nothing about. It was that scenario where you got really nervous if there wasn't anything on the cytogenetics. That didn't help you target the patient, of course. But we absolutely knew nothing about this. And this is where genomics has really come in to its own, I think. So if we look, so why were we interested? Well, these curves tell a story that say we're really good at delivering incredibly toxic therapy to patients. So this is actually data out of St Jude. They run studies in acute lymphoblastic leukemia called total studies. So this goes with, I've now completed total 17, so this only goes to 16. The overarching take-home message from this is outcomes have improved. This is only in children, but outcomes have improved in children. We can give children incredibly toxic levels of chemotherapy and they will survive. That's not the case for anyone any older, as you all would be aware. The other problem, of course, is that we've reached the limit of tolerable toxicity, even in children. So to improve these outcomes, these are good outcomes in children, but they are not good outcomes and not shown here in adolescent young adults and neonates. So we're struggling now we can't add more therapy. The induction will cause death, and we know in adolescent young adults, really pushing the level of toxicity, actually, we see a higher rate of induction death. So yes, we've made progress. Yes, in children, we can deliver relatively good results, but if they relapse, we don't deliver good results. But we know nothing about that group of patients who do badly, who do relapse, and very little or knew very little about the makeup of the disease in adolescent young adults. So our approach when we started doing this was really to take clinical trial samples and real-world data. And to be honest, this moved very rapidly from a few sites of interest in Adelaide to let's look around Australia, and then also to the inclusion now of these assays within all of the data that with all of the clinical trials that are now run. So this is a two-way street. So we take samples from clinical trials and real-world clinical data. So patients who are diagnosed but don't end up on a clinical trial, really rare in the children setting, but not so much so in the adult. And we look at genomics, functional genomics, look at different things about the protein and its expression, and we do some drug screens, very rudimentary, to be honest. We haven't progressed that work particularly of late. I have a large team of basic biologists, but also PhD students, and the other thing that feeds out of this, of course, is the basic biology, so the understanding. And here we do some other sequencing techniques, but also look at in vitro and in vivo modeling from the patient samples. So we have a lot of little mice avatars that can explain the disease, or that we use to explain the disease. And it's really important because this is still discovery. We don't know. It was only 2 years ago that we published one of the later papers showing a whole new subset of ALL that had not previously been identified before. So SAHMRI is well equipped, as you've seen, with core facilities. As I said, our students and postdocs do this. We have a lot of, these are specifically bred immunocompromised mice that we can deliver ALL to, and we can use treatment to ascertain whether there's going to be sensitivity or not. But we don't use nematodes, as I said, we don't use flies. Our work is primarily as close as we can possibly get to the human interface. So let's take a step back again. This is where I started, and this is basically where I said at the turn of the century, there was several subgroups that we knew, many that we didn't, and we needed to sequence these. And as a result of that, we have made the disease much more complex. So, from this to this looks incredible. I can tell you that we now know there's at least 23 different subsets within B-cell ALL. So from that 8 or 9 to start with. That is a Pandora's box. But the good news is for many of those subtypes, through worldwide collaboration, we now understand a little bit more about them with some caveats. So we can assign risk to most of these. We can show what particular gene fusions, if patients have, they will have a poor prognosis or a good prognosis. And this is important for upfront therapy. So what sort of protocol should they go on Should they be transplanted or should they not be transplanted moving forward? So I think that I'll say it here and I'll probably say it again. One of the things that we need to be really careful here in this and probably other diseases is that ALL is a disease that spans the life course. And a lot of the information is taken from the childhood setting because that's where we have the most patients. We're now discovering that we need to think about how we treat a 20-year-old in comparison to a 2-year-old. Because if they both had, for example, a JAK-STAT lesion, it doesn't mean they're both going to respond the same. And, you know, I've spent a lot of time nationally talking about children and adolescent young adults, and adults are not just big children. There are different things we need to look for in their genome. So this is there are some nice things about this data that there are many nice things about this data, but when we started really getting into, so we've done over 1,600 cases now. And what became really evident was, so this looks like, I appreciate this is called a Tisney plot. It looks like a whole heap of little grey circles. That's what it is. But if we overlay this, what you can see is each gene fusion or each subtype actually clusters. So this is the gene expression profile of about 1,200 patients, looking at the expression profile off of sequencing, and we can see they cluster. So it's very easy for us to sequence samples, she says. It's very easy for us to sequence samples and really put them on this sort of plot. And pretty quickly, we know what sort of subgroup of ALL we're dealing with. But you actually have to have a fairly large number of patients. Does subtype matter? Why are we bothering? Is it just giving it a name? Well, I think this data again from St. Jude's probably tells a story. You know, I'd love to be able to plot this, but it would take many years before we have enough patients in Australia. So this is many thousands or several thousand patients from St. Jude's various cohorts, looking at the different subtypes. So you have DUX4, you know, favorable, PAX5, variety of different lesions. I won't go through them all, but what you can see in event-free survival is they stratify. In other words, knowing the subtype will give us an idea of what the risk to that patient is. Clearly, what you can see here also is that in adults, it's worse. So the event-free survival is significantly poorer in adults than it is in children. What we need to understand here is that this is historical cohort analysis. ALL is traditionally treated on a risk-adapted approach. What that means is that even the majority of these patients over time would have been given a transplant, probably our most toxic therapy yet. And so this sort of data gives us an indication, and it's important, but it doesn't tell us how we should treat the patient when they're diagnosed today. And that's really until we start looking at subdividing or treating these patients based on different subtypes, we won't have a really good prognostic look. We have some, of course, you know, we're all using risk-adapted treatment. So therefore, you know, we do know what they will look like in the current treatment approaches, but we probably need to understand a bit more, and that will come with the fullness of time. But I think clearly here you can see that subtype matters. If we look at something like Ph positive ALL, they all have the same chromosomal translocation. So they've all got a 922 or a Philadelphia chromosome. But what we also see are focal gene deletions. So these may just be single exons within a gene that affect the development of these cells. We can cluster these and say about 40, I think it's probably closer to 50% of patients have these gene deletions. They're just single gene deletions, as I said, or single exons within gene deletions, but they make an incredible impact. So when we look at this, particularly if we just focus on what is my right-hand side here, we can see that if you have less than 2 gene deletions, your outcome, I mean, this is a poor outcome disease, but your outcome is significantly better than those patients who have 2 or more. Very subtle difference, impossible to detect without using a next generation technology of some sort. Incredibly different outcome prognostically. Therefore, much earlier intervention would be required if you had this data up front, and therefore probably the patient would be transplanted very early. So single gene deletions matter, and actually knowing them up front can change the course for the patient. This is a little more complicated. Am I going for time? A little more complicated, but basically, if we're looking at minimal residual disease, we know that this is predictive. We know it's predictive of outcome. If you have minimal residual disease at the end of induction, end of consolidation, then you'll probably do significantly worse. It's the brown line than you will if you have it earlier. If you achieve minimal residual disease. If we look at genomics, so this is work we've just published, if we look at the genomics and say you have standard or good risk genomics versus adverse risk or poor risk genomics, you can see how predictive this is of overall survival. So those patients who have high risk genomic alterations do significantly poorer. And so it's important to know that really very early. If we combine the two curves, really what this tells us is if you have a patient who has standard risk genomics, it doesn't matter what happens with their MRD, they actually do really well. If we can actually get those patients who have adverse risk genomics into MRD negativity, they actually do much better as well. So really quite important information feeding back into the clinic. Really quickly, this is a case report that I thought might be interesting because it's maybe something you could run across. So this is a late relapse of a good risk ALL. So a 33-year-old female who was diagnosed 20 years ago with B-ALL. She seemingly was in long-term remission, as you would expect after 20 years, and had a past medical history of osteopenia, thyroid nodules, and endometriosis. She had a recent history of marked fatigue, and her bone marrow biopsy, which demonstrated relapse of B-ALL. So the sample was sent to us for sequencing, and this is that clustering I showed you before. We showed that it clustered with ETV6 RUNX1, so good risk disease. We could show, and we won't go into this, but this is actually the gene fusion here with the blue arrows, and we can see that there are gene deletions that I may not necessarily have expected in one of these patients, but again, focal gene deletions in a good risk disease. And so the question was asked, so we hadn't seen this patient diagnosed. No one would have sequenced this patient 20 years ago. So we asked the question whether it was late relapse of an original disease or clonal evolution or a new disease. So it pays to have collaborators all around Australia because the original clinician who wasn't working anymore could be contacted by another clinician who remained working, and they dug out a sample from a freezer. Sent it to us. It was not the greatest sample in the whole wide world, but it was 20 years old. And at the time, they weren't doing anything to define ETV6 RUNX1. So it was called a cytogenetically normal ALL. We looked at it, and this is this sample. It basically clusters right with the original sample, has the same fusion and messier, but the same gene deletions. So this is 20 years on, looking at a 20-year-old sample, digging it out of someone's freezer, and what we could demonstrate was this was late relapse of the absolute original disease. I have actually manually curated this from beginning to end, and I could not find a difference between the two. So late relapses occur even in those patients who appear to have been well for a very long time. I won't go into this, and I think that this is maybe an interesting area of work to follow up, but we are looking a lot more now on looking at the metagenome and the immune system and what its effect on ALL is, and I won't go to the reasons for that. So we have another mouse model that we're using. This is a germ-free mouse model, which allows me to give the mouse leukemia, but also change their microbiome to see if we can influence their immune cells. And what this graph tells us is that when we give our mouse antibiotics and disrupt their gut microbiome, as we know that they do, the cells grow much quicker. So this is a big area of exploration for us at the moment. We're also looking at late effects, and again, something that would be worth talking more with this group about. Those patients who are 20 or 2 to 25, 30 years on from ALL, we have got some evidence that actually their immune system has not recovered, and this is recapitulated globally. And we're trying to look at those patients to see what we can do to understand this more. So it has been a cook's tour. Sorry, I felt like I went through that very, very quickly, but hoping there were some takeaway messages from that. And thanks again.
Thank you, Deb. Certainly, it reinforced for me the privilege we have in South Australia of having quaternary referral centres.
Yeah.
For patients to be able to access this precision. And certainly your last slide was where I was actually going to go based on the case study that you presented, because the young woman that you described with her past medical history appeared to me to have some features that could be attributed to dysbiosis in and of themselves.
Absolutely.
So I was going to ask to what extent, as generalists who are probably more likely to deal with a survivor of this disease than necessarily make the initial diagnosis at any one time. And the initial diagnosis clearly get them to a subspecialist, but the survivors come with all sorts of issues. To what extent do we look at strategies that can improve immune function, potentially reduce the dilemmas that insulin resistance, for example, might be causing in relation to the microbiome, etc. Is that an area again where precision medicine can help, or is that a general thing that we need to look at for everyone?
I think it's look, it's an emerging field. I'm half brain dead, having written 2 grants on that exact subject, really. So I think it's an emerging field. So MRFF have given us some funding to look at ALL patients across the disease course. So I think there's 2 areas that are of interest. One is to understand our survivors now, and to be honest, they're never seen. So if you're an adult survivor of childhood ALL, you're not seen by your pediatric oncologist when you're 20. You're kind of maybe seen by a GP. You may go to a survivor clinic, but not many do. And so you're kind of set free. And the ability of many of our clinicians to be able to link the 2 together is actually quite hard as well. So we're working at both ends of the spectrum. So with the gut immune study, which I'm happy to, and in fact, we've got some flyers, I'm happy to talk about this at another stage. We look at patients, and it's crowdsourcing to some extent. So the patient themselves, we want to get the flyers in the GP clinics, we want to talk to the GPs, we want to talk to the survivor clinic, and it's up to the patient to read the QR code. And most of our, survivors who are not my age are really good at doing that sort of stuff. And answer a couple of questions, drop off a fecal sample or stool sample, drop it in the post to us, and we'll look at it. I think that's answering that question about what's happened to these. And the childhood survivor studies suggest that 25 years post-therapy, many of those kids are not normal. Well, many of those then adults. Their immune systems never recovered. Their T and B cell numbers are not the same. And they have never recovered their gut microbiome to be normal. In other words, they're still dysbiotic. I believe, and we're doing some work here looking at short-chain fatty acids and understanding what's going on with that. Can we change diet? But I think that's an intervention. So this is where the other side comes on. The beginning is, and that's that work that I showed you where the mouse cells grew much faster when we disrupted their gut, the gut microbiome of the mice. And I think that's where we need to understand what we can possibly do at that stage. Is it an FMT? Not many. Fecal microbiota transfer. Not many people like that concept. Is it? So the other thing we found is that the BMI of patients on ALL6, so that's the AYA cases, those who did poorly had poor risk genomics and high BMI. And that was a really strong correlation, and about 87, I think it was, % of patients who had a high BMI also had high risk genomics. So there's something going on there. So we're teasing that out. It took us 2 years and a lot of pain and a hell of a lot of money to get a mouse that we could change the gut and we could give them leukemia. And so that we can look at cause and effect in that model. So it's a watch this space, but pretty exciting because, look, honestly, if all we have to do is increase fiber in a diet, or we have to give them their brother's FMT, purified FMT, or we can give patient-specific bacteria, and none of that we don't know for sure. Is it a precision medicine? If it gets to that level, it definitely is. Then we think will in some cases be able to reduce the amount of therapy that they have to have, but also increase their quality of life afterwards. Because I guess, if we're talking to hematologists about this a couple of years ago, they'd go, well, they survive. But if you talk to the patients, and so I set up a large consumer group, and the patients say, yeah, but, we've all got diabetes and we've got metabolic disease. And actually, how come no one's told us about this before? So it's kind of important. And I think they're the guys that you're going to be seeing. I mean, you'll be throwing your ALL cases in an ambulance and sending them somewhere else, probably, as you mentioned. But these are the people that really need to be managed well, I think. And that's probably starts at the beginning, but we've got a whole heap of people out there who've got problems now.
Fascinating, and certainly links, very much to a number of studies that we're looking at around the metabolic health and the impact that has on a large number of disease states, and community wellness and those larger social determinants of our health and well-being. Thank you so much, Deb, for
Absolute
sharing that depth of expertise and also making it relevant to we generalists who see
It's been a pleasure.
And we look forward to further collaboration. Thank you, everyone, for your participation in our Grand Round. The Academy exists to improve patient outcomes through linking education and research, and these Grand Rounds are a very important part of it. So, Nakan, and we'll see you again at our next Grand Round.